Hello, I'm Dr. Robert Klitzman. I'm a professor of psychiatry and director of the master's and online certificate and course program here at Columbia University. And we're delighted to have you join us for a conversation with Dr. Joseph Fins. Dr. Fins is a professor of medical ethics and director of the clinical ethics service at Weill Cornell Medical Center. He's an internationally known researcher who's done phenomenal and important work understanding issues at the cross-section of neuroethics, neuroscience, the brain, neurology, psychiatry, and other fields. And most importantly for today, he's the author of a new book, Rights Comes to Mind, and we're delighted to have him here to tell us about the book. So to start off, Joe, tell us about the book.
Well, thanks, Bob. It's great to be here. So the book is the culmination of 10 years of working in the vineyards of neuroscience and neuroethics. It's really a collection of stories that tell a bigger story about this area of patients who were minimally conscious, who were at liminal states of consciousness, not vegetative, but people who are often mistaken to be vegetative. And it's really a clarion call for society to treat them better and to bring them into civil society. Tragically, what we've discovered is that we've been neglecting this population, conflating them with the vegetative state, the permanently unconscious state, but in fact they're actually conscious. They demonstrate behaviors episodically and intermittently. They're misdiagnosed at a staggeringly high rate. The most recent study said that 41% of patients with traumatic brain injury in nursing homes are actually mistakenly diagnosed as being vegetative. So do the thought experiment. You're conscious, you're awake, but everybody's treating you as if you're not.
Right.
So I've been working with colleagues at Cornell and looking at mechanisms of recovery from these brain disorders using EEG, fMRI, PET scan to understand the neurobiology of injury, recovery, resilience. And in tandem with that work, I've interviewed over 50 families to get their stories, to put a human face on this mind-brain challenge. And I've written a book to explain the science by using the family stories to bring people in and realize that this is not a question at the margins, but it should be really a question at the center of our consciousness. And the book, Rights Come to Mind, is really to argue that this is a civil rights issue, that consciousness is a civil right. If it's there, it needs to be recognized, and if it's sort of liminal, it needs to be augmented. Because if we can restore consciousness and we can restore communication, it's the only way we know that someone else is conscious, because we interact. I never know that I don't know you're conscious, except, well, I know you are.
Sometimes
but
I'm not
sometimes
sure
you're
either.
not, right. But I only know that you are because you're communicating with me. So communication becomes a proxy for consciousness. So the holy grail in this area of neuroscience is to overcome the inability of these people to get outside themselves and to express whatever is still in there. And with the restoration of consciousness and communication, we restore community. We bring these people back into the nexus of their family. So in a nutshell, Rights Come to Mind is a history of the science, history of the relationship between neuroethics and neuroscience, and the right to die, and how science has made us aware of problems. We didn't know these people existed until we understood that they were there because of neuroimaging and other things. And we also have technology that might help us resolve the problem by giving them neuroprosthetics to bring them back in and help us communicate with them.
Right, so there's a lot of questions comes to mind, and for those who are watching this live, we welcome you to send your questions as well. So please feel free to email us now any questions that you may have, and we'll be delighted to ask them of Dr. Fins. So let's say I'm a doctor and I have a patient here who's come into the emergency room in coma, as we used to call it.
Right.
How do we know if the patient's still conscious or not?
Well, we still call it coma. And it's really good that you asked that, because we often, these brain states, these categories have to be understood. So let me just give a basic primer. Coma is an eyes closed state of unresponsiveness. And that is the absence of any kind of interaction with the environment. It's a self-limited period. It lasts for a couple of weeks, unless it's induced, like with drugs or anesthesia. After that, the brainstem recovers, the lower part of the brain, and people's eyes open. So people are in a state of what Fred Plum and Brian Jeanette described in 1972 in their famous Lancet paper, a state of wakeful unresponsiveness. Simply put, the eyes are open, but nobody's seemingly home. And that's the vegetative, what they describe as the persistent vegetative state. And that was an important state because that was what Karen Ann Quinlan was in. And that brings us to the whole right to die story, which I think we'll get into in a moment. From the vegetative state, it's just thought to become persistent at a month. And then it becomes permanent at 3 months after a anoxic brain injury, like in a cardiac arrest, and a year after traumatic brain injury. At which point, there's no hope for any additional recovery if you were properly diagnosed. However, in that period before persistent becomes permanent, and one of the big things, one of my bugaboos is, let's not call it PVS, because P could stand for persistent or permanent, and it just leads to confusion. So let's be very precise in our language. So the persistent vegetative state, these people move into nursing homes, and they move into the minimally conscious state. And they carry this diagnosis from the hospital, and it stays with them. But in fact, the minimally conscious patient is actually demonstrating behaviors which suggest that they actually are conscious. So what they'll do is they'll track somebody when they walk into the room. They'll grasp for a cup. They might even say their name. But of course, when the family says, Dr. Klitzman, could you come in and see Joe? I think he tracked the guy who just walked into the room. Joe doesn't do it. That's the biology of the minimally conscious state. It's kind of episodic and unreliable. And so, of course, most doctors who see that, the person came from the fancy medical center with the diagnosis of being vegetative, the family is seeing things, and it's not reproducible, so they chalk it up to denial. But in fact, it's quite possible in many cases people are actually doing these behaviors, and it's not consistent. When they emerge from MCS, they are now reliably following commands or reliably communicating, and then they move into higher levels of function. So the person who comes into coma is at the beginning of a pathway, and coma could also lead to brain death, which is whole brain death. So that's the sort of the architecture of the diagnostic space.
Right. When I meant coma, obviously, I think what's happened is in the past 20 years, 30 years, there's been a whole expansion of our understanding of the various complexities and levels and stages that happen. It used to be coma was coma, and now we're understanding much, much more. It sounds like.
And in fact, my teacher, Fred Plum, wrote a book called Stupor in Coma.
Yes, right.
And the whole point, which I think was first edition was 1966 with Jerry Posner, and the whole idea was to disaggregate and begin to understand these various brain states. Yeah.
So let's say someone has minimally conscious state, and sometimes they track someone, or they'll reach for a cup, other times they won't. So what's going on in their mind, so to speak?
Well, the problem is that they're not at the level for us to tell us what's going on. And if they recover to a higher function, they're often amnestic for that period of time. So we don't really know. But what we do know is that if you put these folks into a scanner, and they might have a diagnosis based on behavioral criteria, being vegetative because they're not following commands, and you do the thought experiment. It's done by Adrian Owen in Cambridge, and then we did the same study modified in New York. Imagine yourself walking through your house playing tennis, disaggregating words that are similar linguistically. These people activate, with an active paradigm. It's not passive, but an act, because they're actually trying to do something. Motor, spatial, and language networks in the brain. So they'll actually increase metabolic activity, have a flare on the fMRI, which shows that they're processing information, which is quite staggering because if you look at them at the bedside, they may appear inert. So it's this discordance that technology has opened up for us to be aware of that really creates the ethical challenge. Like, oh my God, they're there, we've treated them as if they're not, but they're actually interacting with us. An earlier study, the one that gave me real goosebumps, in fact, I was quoted on the front page of the New York Times, was my colleague Nico Schiff, with whom I partner in this work, and we co-direct CASB, the Consortium for the Advanced Study of Brain Injury at Cornell and Rockefeller. Nico and Joy Hirsch, who used to be at Columbia, now at Yale, did a study where they played narratives to patients who were minimally conscious, and forward narrative and tapes. Remember, Bob, when we were kids and Mom did this, that, and went to the beach, so it was emotionally laden. Then you play the tape backwards with the same frequency spectrum. They lit up language networks only in the forward direction, which means they were processing language. They were responding to language and not gibberish. It wasn't the sound, it was the language. And to me, that was like a real wake-up call, no pun intended. that these folks were able to interact with us and perhaps understand what we're saying. And we've been treating them, as if they were unable to process language or understand the conversations. And for me, that changed, how I talk to patients at the bedside. If they're unconscious or they seemingly are unconscious, I always take it outside and go into the hallway. Let's go outside. Let's not talk about people, because we don't always know what they're doing on the inside, and that's a great challenge.
Right.
Sorry.
All right, so there's a lot of patients who fit in this category. What should we all do?
I think we should be precise in our language. I think we need to support families. I think we have to be able to, one of the themes that came up in the book was these families, Lee and Bob Woodruff, the ABC News journalist who had an injury, a blast injury in Iraq, has the title of her book is called In an Instant, In an instant, these families are submerged in a nomenclature and diagnostic categories that most doctors don't even understand. So I think we have to be very helpful in navigating that course. We have to be very sensitive to the stress of this acute thing that happens to you in your loved one's life, and then help them understand what these brain states mean. That there's a lot of conflation of language, so that's the first thing. The second thing is we have to make sure that people are properly assessed. So people who are minimally conscious, because the behaviors are intermittent, one time point in the assessment won't do it. And you have to have multiple assessments at different times of the day. People have sleep-wake cycles, they have diurnal variation, so they may be more alert in the morning. Drugs may have an impact on their level of arousal. And the diagnostic category that we put them is not what they usually are, but their highest level of functioning. So if somebody actually demonstrates grasping for a cup or saying somebody's name, that means they are minimally conscious, even though the rest of the time they look like they're vegetative. And the reason for that, and go back for a second to the fundamental biology, is that the minimally conscious state is a brain state in which the networks are intact but underactivated. The permanent vegetative state is when the networks don't exist anymore. So it's kind of like the interstate highway system. And if it's out there and the roads are there, you can drive from here to Seattle. Whereas if it's all been cratered out, you can't do that. And the job for the neuroscience, the drugs, devices, and the like, is to get cars on the highway and use those pathways that have been inactive, but activate them. And that can be done with deep brain stimulation and drugs and other things.
So, and obviously there's a lot of issues here involving both the science of the brain as well as the ethics and psychosocial issues of how we interact with patients and their families about these. So we'll talk about each of these. But just to step back to the science, so if we were to say how conscious a minimally conscious person is, I mean, are they with it, so to speak, a little bit 5 minutes a day, 10 minutes a day, 5 minutes every hour? How do we understand sort of the process over time if they'll track today when I'm in the room, but nothing when the doctor comes in?
Right. So, this no one knows the answer to that question. We're collecting, my colleagues at Cornell and Rockefeller are collecting terabytes of EEG data because there may be some correlation between normalization of EEG during the 24-hour period and the actual behavioral manifestations of awareness and consciousness. And the point is that it's not so much how often they are, but whether they have the potentiality to do this or not. And if they have the potentiality, the idea is if they have these oscillations, how do we get these oscillations to move up to the highest oscillation and use that as a baseline and build upon that? Right. And that's really what happens as people recover.
So let's say here's my family member and they're in this state. What could the doctors do if I say, could the doctors do anything to bring the person back in some way? Right. What would you say, or as much as possible? Right. How much can they be brought back?
Right. So the evolving standard of care, some of this is investigational, some of this is off-label use, but neuropsychologists, physiatrists are beginning to use drugs like amantadine and zolpidem to help activate those circuits. We did a study back in 2007, published in Nature, where we used deep brain stimulation to turn a patient a subject who was only able to communicate by moving his eyes, who was able then to say couldn't eat, had been assaulted, and had been very stable baseline, had initial Glasgow Coma scale of 3, which is as low as it can go before you die. Stable baseline, got deep brain stimulation, and now could say 6 or 7 word sentences, could say the first 16 words of the Pledge of Allegiance, could tell his mother he loved her, could go shopping with her, okay, and voice a preference at Old Navy, and eat by mouth for the first time in 6 years. You turn the stimulator off, he couldn't eat. And so all these things are manipulating a circuit that has been described as the mesocircuit. And the mesocircuit is basically getting output from the thalamus to the cortex and down into the brainstem. The thalamus is to the brain what Hartsfield Airport in Atlanta is to Delta Airlines. It's the hub. Even if the cortex looks good, you can't get there from here without going through Atlanta, and I do that a lot on Delta Airlines. So the point is how do you activate that thalamic output? And so the deep brain stimulation directly drives the thalamus. For certain kinds of injury, that will work. The amantadine and zolpidem inhibit inhibitions from the basal ganglia on the thalamus that put a brake on the thalamus. So you inhibit the inhibition, it leads to thalamic release. Dopamine also, with echoes of Oliver Sacks, dopamine also directly drives the thalamic output, and it activates the mesocircuit. There's been some beautiful PET scans using zolpidem, that's the sleeping pill, Ambien, where a patient has hypoactive frontal cortex, and in certain less than 20% of these kinds of patients, you give them zolpidem and their frontal cortex lights up. So these are some of the probative things that people do. The deep brain stimulation is investigational. It's just at the level of proof of principle. I'm not establishing that as a treatment, but the amantadine and the zolpidem, these are things that neurophysiatrists are beginning to do regularly in the context of when people come into rehabilitation. The problem is that most people don't get rehabilitation. And if you haven't gotten to a certain level of function, you won't qualify for rehabilitation. It creates a tautology. So the insurance company will say, well, they're not ready for rehab, but when they get better, we'll bring them back, from the nursing home into rehab. But if the diagnostic error rate is 41%, they're not going to be properly assessed and they never come back. And sometimes it can be a little thing by getting proper rehabilitation or assessment by a neuropsychologist early on, it changes the diagnosis. So I know a case of a patient who couldn't speak, so they looked like they were vegetative. Then the patient got proper speech therapy, and the speech therapist sort of coaxed along the speaking by moving their lip, and the person was then able to speak, change their diagnostic category, and all of a sudden they're eligible for rehabilitation. But then once you get rehabilitation, there's the challenge of what's called medical necessity or the improvement standard. If you don't get better by a certain point, we don't pay for it. And of course, better is complicated, right? Because better in your head or better in your arm movements and your somatic manifestations. This is a somatic criteria, and brains recover by biological mechanisms, not by reimbursement criteria. And if it's too late, right, based on what Medicare says, the biology might take longer. We have to recalibrate the clock, so what is on time is what the biology says is on time. And there's been some recent litigation looking at the improvement standard, and Medicare has just entered into a settlement with the litigants, a case called Jimmo versus Sebelius, to rewrite the Medicare handbook to look at these issues. But unfortunately, what happens on the ground in what's called the local care determinations still precludes people from getting care, even though the federal regs don't allow it. So there's a lot of work to be done, and hopefully some more litigation will hammer away at that.
And just to give us a sense, how many patients fit this category of minimally conscious state, would you say?
Great question. We don't know. And the estimates are somewhere between 100 and 200,000. The problem is that the Glasgow scales are based on behavioral manifestations. The best scale is the coma recovery scale, which measures level of consciousness. But that's not routinely used. And we had a meeting back in 2007 at the Institute of Medicine calling for a demography of this brain state, and it still hasn't been done, which was reflective in large part of the neglect of this population. You can't plan for the needs of a population if you don't know how many people there are. And then The problem is also what I call the neuronal in the book, the neuronal diaspora. We know where the ambulance takes you when you have a brain injury. We don't know where they take you when you leave. And there are lots of people who are sequestered away at homes, in their homes, away from institutions. They're not being counted. And we've never done a kind of systematic survey of how many people there are. We've studied a small number of people in depth, but we need to do a bigger demographic study. And I'd like to maybe explain why this hasn't happened and why we've neglected this population, which I think in bioethics land, I think is really, especially interesting.
Yep.
You know, the right to die was established in brain injury. And in the Quidlin case back in '76, where Fred Plum, who was a co-originator of the vegetative state, was asked to testify by Judge Hughes. And Fred testified that the brain had a cognitive and sapient state and a vegetative state. And it was a loss of the cognitive and sapient state that was the moral warrant to allow Judge Hughes to allow the ventilator to be removed in Quinlan because she wasn't going to recover.
Right.
And so the right to die grew up in brain injury. But what we did is we generalized that kind of nihilism, the futility of that brain state, to brain states that looked like this brain state. And nestled within the vegetative state was the minimally conscious state, which didn't become a category until 2002. So so we've generalized the nihilism. So we look at these people, we think it's futile, we're not going to be able to help them, and so we give up. We don't bother properly diagnosing them. We don't bother counting them. We don't do health policy around their needs. And sort of what I've been trying to do is saying, you know, they're really different than vegetative patients. It's, you know, if Terry Schiavo had been minimally conscious, that would have been a very interesting case, and there will be a case like
Right.
that. And how do we negotiate that terrain? It's going to be very interesting.
So let's say I have a family member who's in a nursing home, and I think maybe they tracked me recently when I was there, and I once I saw them reaching for the glass. What should I do?
You know, you might the knowledge base that the level of the dissemination of the knowledge base hasn't reached to those places, and the families that come to see us, you know, probably the biggest sample in the United States. Certainly, you know, we've done. I met a family this morning. Actually, it was our 54th family. You know, they have nowhere to go because it's often ignored, and there's no one there who knows that there is even a category for this. So it's very hard, and they come to. There are a few specialized centers, but it's a handful, and we have to generalize the competence. So they should probably look for you know, specialty area programs in their area. And you know, there are a few great places like Spalding in Boston, and RCI in Chicago, Braintree in Boston, Moss Rehabilitation in Philadelphia, and a few others. But it's not generalized. And the other problem is in the VA. There are polytrauma centers that have great expertise. The Tampa VA in Florida, for example, is superb. But you know, there's no heart in the heartland. So if you've got this kind of brain injury in the middle of the country, the expertise doesn't follow where the people go. So you know, there are some on CASB, our website, casbnyc.org. We have some resources for families to look, and the American College of Rehabilitation Medicine and these programs have websites that might be able to direct people to expertise that's local. One of the challenges is these people are not that mobile, and so we have to bring resources into the communities. And I actually just wrote a chapter for the new Oxford textbook of palliative medicine, suggesting that hospices assume some of this function, you know, because they can provide respite care, they're great at talking to families, and if we brought some technical expertise into hospice, we might be able to bring, and every community has a hospice, we might be able to bring this expertise closer to the needs of these families. Not to say these people are dying, because they're not, but rather to use that infrastructure to provide services which are sometimes hundreds and thousands of miles away.
Now, we also read about or have heard about Lockedin syndrome.
Right.
Some people know there was a movie a few years ago, a French movie.
Right.
You probably remember the name better than I do.
Diving Bell and Butterfly.
Yes, right. So how is this different than that, would you say?
Right. So that is basically the ultimate in cognitive motor dissociation. So there's no motor output except above, at the cranial nerve level. That's why he was able to write that book with moving his eyes. But he was intact cognitively. Minimally conscious patients are kind of like locked-in patients to some extent, but they have a cognitive impairment as well. But the line gets blurry between the upper level functioning MCS patient and the locked-in syndrome patient. And on those neuroimaging studies where they say yes and no, the fact that they do that tells us that they are conscious and they're following commands, but it's a floor. It's not a ceiling. And in fact, they may be more functional and closer to locked in than we think.
Now, my understanding from some of the research is that some of these patients who can't move, if you tell them in an fMRI machine, think about this,
Right.
if your name
Right.
is Joe,
Right.
think this,
Right.
if your
Right.
name is Bob, think that, and we'll see that they're actually processing
Yes.
information. So should we be using that kind of technology more? Is that a way to communicate
right.
more?
So
Is that practical?
That's the paper I talked to you about before. They took the Adrian Owen paradigm, and Martin Monti published this in 2010, toggled that to yes, no answers. So think for yes, playing tennis. Think no, walking through your house. It turns out that it is not very sensitive, and that the bedside exam, the coma recovery scale, done by an expert neuropsychologist on multiple occasions, has better sensitivity than the neuroimaging, okay? So in that particular study, I think 30 of 31 patients were identified using the bedside coma recovery scale methodology. One patient who appeared vegetative was identified as not being vegetative because they were able to do this yes-no thing, which was on the cover of the New York Times. The problem was that some of the people who were able to do it on a motoric basis weren't able to do it in the scanner. But I think that we have to use all these tools to make the proper diagnosis. So for tiebreakers, when you're not sure, you can use the neuroimaging as a tiebreaker. And EEG is also emerging. The normalization of the EEG may be also a predictor or a Bayesian pretest probability that in fact normalization of EEG, maybe you're going to be more likely to follow commands even if you're not actively doing it right now. So the most important thing, though, goes back to basic, medical school, history. If you had a traumatic brain injury, right, you're much more likely to do well and recover than if you've had a noxic brain injury, unless you got therapeutic hypothermia, where your brain is cooled with the saline. Then you're going to be actually responding more like traumatic brain injury.
And just to clarify, anoxic is when there's no oxygen going to the brain
right.
for at least several minutes or
Correct.
so. Right.
Right. And they have a worse prognosis. Right.
So let's talk about policy and ethics, coming back to that for a moment. So if you were in the White House and you were writing the Affordable Care Act,
right.
or the Affordable Care Act is now being, the details are being worked out,
right.
what is in there regarding this and what should be there?
Right. Well, actually, the original draft didn't have anything about rehabilitation. And Pierre Carasoni, who was Gabby Giffords' chief of staff, after Gabby Giffords was shot, wrote a letter to Secretary Sebelius, which I quote in its entirety in the book, saying we should have rehabilitation as one of the pillars for the Affordable Care Act. This was lobbied for by the Brain Injury Association of America and other groups. So rehabilitation in the original iteration got short shrift. What I would lobby for, and it was included, but it only goes up to a certain age, and the question is access, but how good is the access to care? So the first thing, if I could pay for one thing, I would want to be sure that at that 3-month window or that 1-year window, before we declare somebody as permanently vegetative, I want to be damn sure that diagnosis is right. Because I think once you get past that barrier, that threshold, they're labeled forever. And then people are just going to ignore them forever. So I would want to have proper diagnosis. I would also want to revisit people who are minimally conscious on a periodic basis, because the brain changes. I mean, one of the things that is remarkable is that these brains, we've never seen brains like this before in the history of humankind. And people who were this brain injured before 15, 20 years ago just died. But over the last 15 or 20 years, we put in shunts, We do craniectomies. We allow the brain to swell and not herniate, right? And the swelling happens, and then the brain recovers, and they have significant injury. And this injury somehow has prompted a regenerative process called axonal sprouting in some cases. That is exactly what the developing brain does. So that you have new connections between remaining neurons. Not every time you get bopped on the head, but after a significant hit and a period of time and latency, this thing kicks in. So I'd want to have longitudinal assessment of patients over time. Most importantly, we need to pay for this. We need an ICD code for the minimally conscious state. There isn't one, and we have to rethink medical necessity and the improvement standard because what we see overtly as an improvement may not be what's happening in the brain. So I think we have to have more liberal policies vis-a-vis reimbursement and paying for this. But more fundamentally, and this is because I spent a lot of time categorizing in the book, the family stories and the challenges with insurance and what they didn't get and all that. And I thought that was going to be the answer. And it is part of the answer. But the bigger answer is it's not a reimbursement question. It's not a reimbursement question. It's a fundamental human rights question. It's these people are conscious. It's an affront to their personhood to totally write them off. And so the real thing that's going to help these people is the enforcement of the Americans with Disabilities Act for this population. However, before we do that, we have to secure their civil rights because they have been outside the cone of the law. And I was writing the book and it's like, where's the ADA? I mean, some of the stories are just horrible, like they're in the back wards and they're being, not treated particularly well. And I said, where's the ADA? This is kind of separate is equal kind of argument. This is Plessy versus Ferguson. This is 1896. I thought this was not legal. And I think, the story though is that the dispossessed have to gain their civil rights before they get the protection of the law. So, from Skaneateles to Selma to Stonewall, right? There was a right to vote unless you're a woman. There was a right to education unless you're a little black kid in the South. And until recently, there was a right to get married unless you were gay. Okay? So now, this I think is the next civil rights frontier. I talk to kids in college. Here at Columbia, I did this a few years ago to the Neuro Ethics students. And I said, we have learned over the last decade, the importance of respecting love, and people who love each other should be able to get married. That's really important. And you look at my generation, you say, how could you guys have thought otherwise, right? And they're right. How could we have thought otherwise? Fortunately, we have evolved. I look at them, I say, your kids are going to look at you and say, how did you treat conscious people like that? Conscious people, you put them in nursing homes, you shut the door, and you ignored them. Living in isolation, sequestered from their families, that is a civil rights question of your generation. And Justice Kennedy, in the Obergefell decision, says in his defense of gay marriage, and I think it's applicable to our situation for severe brain injury, sometimes you learn stuff that makes you realize that what you always thought was wrong. And I think the neuroscience and neurotechnology has taught us that what we thought was an inert being, a person who was vegetative, may in fact not be. And that changes the moral equation.
So why has the ADA not been applied? Why has no family gone to court saying... Right,
because it's a new category. These folks are just hanging on with their fingernails to just get the most basic of care. This is not like other advocacy groups where there's a race for this disease or that disease, and either you memorialize someone who's passed or you celebrate somebody's victory over a dreaded disease. These families are in a state of perpetual bereavement and siege. They don't have the luxury of going out and marching. And they get abandoned by their families and their communities and live these isolated, horrible existences. And what we're trying to do in giving voice to their stories is to launch a civil rights movement for this population. And the last couple of years I've been teaching at Yale Law School. and I'm trying to develop, a vector of legal advocacy, so that we could actually have maybe one day a kind of a legal defense fund like mechanism to support these families. I mean, I've heard a lot about cases. They're just struggling. I mean, I know of one case where this one woman was continuously denied care and benefits that she was needing, and while the formulator said the letter was addressed to her, okay, and saying, we understand you're this, that, and the other thing, and they denied her resources that would seem to indicate she wasn't able to read a letter, but the letter was addressed to her. It was this almost offensive, bureaucratic denial of services. I should add that in the book and everything that when I use family names and the like, we had IRB permission and HIPAA approval, and when we didn't, we used pseudonyms.
So we had one question came in, and again, those of you who are watching us live, we encourage you to email us any questions you have or other things you want Dr. Finns to talk about. Question, did Dr. Finns study anyone with Lockedin syndrome while researching his book?
No.
Okay.
But, there may be people who are at the very high end of the minimally conscious state, because of profound motor cognitive dissociation and a paucity of motor output that in fact might have looked like vegetative. The book by Janet Tavellaro, who was at Roosevelt Island, and she wrote a book called Look Up for Yes. She had been misdiagnosed for years. People thought she was vegetative. So it's an excellent question. And some of these patients who might appear vegetative could either be minimally conscious or locked in.
What do you think are the biggest ethical issues that we now face concerning this whole area?
Well, I think one of the issues that comes up a lot is, resource allocation. Why should we spend so much money on these people? And besides the civil rights argument, I would say is that there's a kind of delusion that somehow, I would never want to be this way. No, nobody would want to be this way. You wouldn't wish this upon yourself or someone you loved. However, once people are in this brain state, we need to meet them where they are. And I think that if we could somehow increase their level of function, make them more mobile, make them able to eat by mouth. If deep brain stimulation were to, say, become a therapy and it costs $40,000 to put in the stimulator and whatever it costs, and you start doing a cost-benefit analysis, now they can eat by mouth, they won't aspirate. Now that they can move around some more, they won't get a bed sore. A bed sore costs $10,000 a pop, and the eating by mouth is cheaper than the PEG. And when they start getting a little bit of a cough, it doesn't progress to a pneumonia. You save that. So the money is already in the system, and if we could reallocate those resources by investing a little bit into their functional status, we might be able to save money. So I think people say and I personally think that if we're going to have neurosurgeons and neurologists in the emergency room, there's an ongoing obligation in the chronic care setting to make good on that clinical investment in the acute care setting. So I think that people talk about cost containment and everything, but I think we misunderstand it. And it tends to preclude access to care, which might in fact be cheaper for the entire system.
Now, you're a major figure in the field of neuroethics. If you were to say in neuroethics, what are the other major issues you think that we're facing today? What would you say?
I've been totally focused on this issue.
Okay, all right.
But I think that there's some issues that I think distract us.
Okay.
From this important issue. There's concerns about neuroimaging creep, using it to talk about the human condition in the courts, kind of a neurodeterminism, or questions of neural privacy. Okay, and I think that by focusing on these things, which I think really are distractions, we scare people away from the centrality of the clinical needs. I think that clinical neuroethics is a field that is somewhere between clinical ethics, traditional bioethics, and the more speculative neuroethics. I think the speculative neuroethics has been a distraction, and the hyperbole there needs to be countered by more granular concerns about the needs of real patients and families. And I would say that what we're learning, with disorders of consciousness, may well have application to other brain states where there's cognitive motor dissociation, like autism. Autistic kids have more going on in their head than they're able to demonstrate. And maybe we'll learn something in MCS that will have direct applicability to autism. How do we get them outside themselves so they can communicate? And so I think, to me as a doctor, I'm just a country doctor. As Dr. McCoy said, right, on Star Trek, I really hope that we can mobilize neuroethics in the service of the clinic and the needs of patients and families.
Well said. So take these patients, we don't know how many, how much better do you think most of them can get? So you've mentioned a few things where someone could now eat again. Is that typical, you think? Is that a small percent? What are we talking about in terms of how much better you think these patients might be able to get?
Right. Well, I think again, we have to have bigger longitudinal studies and understand that. But I think, as Maggie Worthen, who was the main character in the book, was a senior at Smith College, had a brainstem stroke, bleeds up to her brain, and Nancy and her mother told me her story over multiple years. Better, is a relative term, but we got to the point where Nancy knew that Maggie knew that her mother was Nancy. They were able to communicate a narrow channel, and they were able to learn how to paint together. So Nancy would put her hand over Maggie's hand and help her paint. And they painted some beautiful things together. And they reestablished a loving relationship. It wasn't the life that Nancy and Maggie had aspired toward, but it was far more than what they thought they had. And I don't want to ruin the book, but I think it's realizing that these other people are still there. And that these kinds of achievements are seemingly small, but can be monumental. To know that your daughter knows who you are,
sure,
and that she's no longer alone because she knows that you're there. As a parent, I can't imagine anything more important. Although, from a somatic level, how independent she could be, she was very dependent on all kinds of things. But I think the neuroprostheses, the technology, is going to give people the ability to overcome this inability to communicate and reestablish connections with people that love them, and bring them back into their families.
What other story? I know there are a lot of stories in the book. What other stories stood out for you, or you think are the most important ones for people to be aware of or think about?
Well, there's one story that involves Terry Wallace, and Terry Wallace is sort of the poster child for the minimally conscious state. He was in a car accident in 1984, and in 2003 he starts talking, and it got international attention. He woke up from a coma. Everybody used the terms incorrectly. It was a miracle. But if you look back, and I have permission from Angela Wallace, his mother, at the medical record, he was vegetative, and about 3 or 4 months after the car accident, he was minimally conscious. But the problem was, it was 1984-85, and there was no category for him to be in. So Angela tells us this really poignant story. Early 90s, he's vegetative, right, because there's no other category yet. And the nurses call Mrs. Wallace up and say, Terry's not right. Now, the nurses hadn't read the textbook. They didn't know that vegetative patients are neither right nor wrong. They just are. And she gets to the nursing home, and Terry, as she told me, didn't look right. His eyes were kind of wide open. He looked frightened. Couldn't communicate, but he looked frightened. And what had happened? The night before, he was in a nursing home. The elderly person in the other bed in the room, who had dementia, had strangulated himself in the sheets and died. And that stayed with Mrs. Wallace. And only 10 years later, when he started talking spontaneously, and it became clear that he had been minimally conscious all those years, do you have the sense that perhaps he was aware at some level that something had happened?
Right.
That's the kind of thing that keeps me up at night. And that's the kind of misdiagnosis, which is understandable in 1992 because the category didn't exist yet. But that shouldn't happen today. And we have to make every effort to know that people who are conscious so that we don't isolate them in this kind of profound way.
So are neurologists now learning this? Are they hearing this? Is this getting out there? You mentioned it was on the front page of the Times.
Right.
Has that led to the right amount, too little, the wrong kind of attention?
There's still a lot of nihilism. And it goes back to this dynamic between Hippocrates and Galen, where Hippocrates thought brain injury was invariably fatal, and Galen refuted it, saying, but I have seen the injured brain healed. And in fact, that combination is the ceiling in the Montreal Neurologic Institute that Wilder Penfield himself designed. There's a Greek saying around early manifestations of the hieroglyphics of the brain, in which Galen refutes the Hippocratic aphorism. So this is an old tension about the invariable horribleness of a severe brain injury. But I think the meetings are getting bigger. I was just at Neuroscience, Society for Neuroscience. Lucky to give the COP lecture on neuroethics on this topic. And the number of posters and the number of people who are beginning to do this work, they're beginning to grow. It's still a sliver of what needs to happen, but from where it started, where you could count the people on your hands, it is getting bigger. But I think it is really a pressing public health need. And it may be a smaller number than something like a pandemic, flu, but the profundity and the longevity of the effects of these injuries, I think, makes it very significant. And again, these people are experiencing this kind of isolation, and I think that their human rights are being fundamentally violated. So it's not just a medical concern; it's a broader juridical and ethical concern.
Have there been court cases, or not yet, or will there be, you think?
I think that nothing really of significance. I've talked to a few families about the prospects of that, and it's incredibly hard to mount that kind of challenge. But I've read the history of the NAACP, and Thurgood Marshall argued the Brown versus Board decision in 1954, started decades earlier, and it was an iterative process, and it culminated with that unanimous court decision which overturned Plessy versus Ferguson. So I think we first have to make people aware that there's a problem, and then we can start litigating it and changing the legal landscape. But I think one of the pockets of resistance, I would say, is traditional bioethics, which somehow thinks that if we somehow articulate the right of these people to live, that we're somehow eroding the right to die, which for a certain generation of bioethicists is kind of one of the great two things they did. They secured reproductive rights, and they secured the right to die. So I think the Venn diagram that we have to construct is we have to preserve the right to die. And my last book was on palliative care. Preserve the right to die, but affirm the right to care for people who need it or want it. And I think that we have to be a little more able to tolerate that ambiguity. And I think the way we begin to tolerate the ambiguity is by disaggregating brain states, so that we're talking about the right to care. We're not talking about people who are permanently vegetated, but rather people who sometimes look like them and in fact have a life of the mind.
So let's say I'm filling out this is a provocative question. I'm filling out my advance directive.
Yeah.
Should we have something if you're in a
minimally conscious
state? What would you have done, or what would you do? Would you say yes, do everything? I can sometimes follow someone, but that's about it. Is that
right? So I'm not a big fan of living wills, nor most for that matter. I'm a bigger fan of designating somebody through an advanced care planning exercise where I designate you to be my healthcare agent if we're in New York, or Durham power of attorney for healthcare, and have this conversation. As like, what would it take for me to have a worthwhile existence? The problem is no matter of prospective planning can always prevent this from happening.
Sure.
Because what happens, and the family narratives have this kind of stereotypic quality. First, I want them to survive the injury. Then I want them to open their eyes. And then when they open their eyes and they're not aware, then I want them to be responsive. And then I want them to talk. And one lady says, and her husband, she said, and then I want him to kiss me. So Kierkegaard said life is lived forward and it's understood backwards. If we knew how it would end up, maybe we would just make a decision to withhold or withdraw care earlier on. But we live in a state of uncertainty. So the question is, when we get to that point, what do we do? So we don't have perfect knowledge. So we don't always know how to apply prior wishes to the situation we're in. So I think the fluidity of the situation really requires preparation, because in an earlier iteration I wrote about the advanced care planning as a contract or covenant. The contractual model is when I say something, you follow it. The covenantal model is really about reciprocal obligations and giving people the discretion to make choices. And I think one of the most important things we can do is, if I designate you to be my healthcare agent or durable power attorney, is that we have the conversation. Because the one person that you're going to want to call when I become decisionally incapacitated is me. So let's have the conversation ahead of time, so that you can then know what my wishes were. And this is one of the scenarios that we should talk about. And the whole book, I asked all the families, I said, is it better for someone not to know, or them to know but not be able to communicate? And it took hundreds of pages to explain how every family's a little different, every story is a little different, and it doesn't reduce itself to the usual simple formulaic responses that often characterize clinical ethics. It's complicated, and it depends on context, and it may change over time. I had a conversation with a family this morning, and the mother said that she had not thought about a DNR order, but more recently she was thinking about it in the context of a serious deterioration, should that occur. So families evolve over time, and it's very complicated. I think getting back to your earlier question, we have to support these families. And we also have to, I think, the scientific community has to realize, the research community, that they have some clinical obligation too. Because of the inadequacy of care out in the generic healthcare system, Henry Richardson wrote a book called Moral Entanglements, and he talks about ancillary care obligations, where researchers, because of the nature of the problem or the proximity to the subject, they sometimes are entrusted with certain kinds of responsibilities and obligations. So I increasingly feel that people in our space, the few of us who do this kind of work, have a kind of obligation and responsibility to these patients and families, precisely because of the superior knowledge that exists in this area, and then the adequacy of care in the rest of the healthcare system.
We just have a few minutes left. Are there other points you think it's important that people understand, or that you think are important to make clear?
I would just encourage all the the students and people in your program, and it's a marvelous program, Bob, and congratulations on building the premier program in New York City at Columbia. It's really great, and I would just urge young people to take this area seriously, and I think it's going to be a growth area for scholarship, for science, for policy, and I think if they really want to make a difference, and they really want to be part of the next wave of a civil rights movement that's grounded in science, it's really one of these places where the two cultures really converge to create a kind of synergistic approach. That they should take this on and write a research paper on it, read the book, come and talk to me, collaborate with colleagues in their programs, because I think it's only going to get more interesting, because the science that's coming down the pike, use of brain-computer interfaces, Google Glasses, other kinds of prosthetics, are going to give people more of an opportunity to communicate. And the question is, how do we incorporate what they're saying into the paradigm of surrogate decision making? How do we incorporate their emergent voice into the legal architecture and the rights of the citizenry? And I think it's going to be very exciting, and it's a journey that I hope others will try to make.
Have you bought Google Glasses yet?
No, I haven't. No, I haven't. Not yet. Not yet. But actually, Maggie, in the book, was helped by a neuroengineer who designed, he describes it as hip-hop glasses and a computer interface that allowed her eye movement to be tracked by a computer, so she could actually say yes and no by looking. She only had upward and downward moving in her left eye. That was her major communication channel. And he designed this neuroprosthetic for just several $100s. He runs a thing called Speak Your Mind Foundation, and it gave Maggie the ability to communicate in a way that she hadn't been able to before. Very primitive, but it's suggestive of the kind of augmentation and not enhancement, but restoration that technology can provide to these people and help work around the cognitive motor dissociation that they suffer from.
Well, unfortunately, we're out of time, but clearly Dr. Finns, I think, has been exploring fascinating areas that are clearly important for all of us as individuals, as family members, as healthcare providers, and as a society as we go forward. So I want to thank you so much for being
Thanks,
with
Bob.
us here today.
Great to be
and
with you.
Please feel free to contact us if you have any questions. I'm sure you'd be happy to answer questions
Sure.
that we relay to you. Thank you for joining us, and thank you for being with us, and congratulations on the book, and good luck with it. I'm sure it'll make a major change in this area.
Thanks so much, Bob. Really,
You're welcome.
Great to be here. Thank you so much.
Thank you.